very welcome to our first Community Healthcare East Health and Wellbeing webinar. Today's webinar is focusing on menopause, and I'm delighted to have the CEO of the Menopause Hub, Ms. Loretta Dignam, here with me today. The purpose of this webinar is to learn more about what menopause is and isn't, the symptoms of menopause, and tips for managing menopause. We encourage your participation by asking questions through the chat, and we will answer them to the best of our ability. I say we as in the royal we, because I'm hoping Loretta will answer them to the best of her ability. The webinar will be recorded and will be available to watch back on the Community Healthcare East YouTube channel. Please let your colleagues know. We plan to follow today's webinar with a series of webinars focusing on specific areas of health and well-being, as well as delving deeper into the topic of menopause. Do provide us with feedback as to what topics you would like us to cover in future webinars. So, without further ado, thank you for your attendance and participation, and I will now hand you over to Loretta.
Thank you very much for that introduction, and good afternoon, everybody, and thank you for having me here. So just a little bit about me and how come I'm talking about menopause is that when I was 49, I had what was to be my last period. I didn't know it was my last period until 12 months later when officially I was post-menopausal. But very soon after my period stopped, I got hot flushes. And they were the only two things I knew about menopause, no periods and hot flushes. So I was able to work out that I was menopausal. And the three things that struck me were, one, that I was way too young for this. Surely this affected women in their late 50s, 60s and older. And my perception of a menopausal woman was somebody a lot older than I was. The second thing was I knew nothing about it or how to manage my symptoms. So I quickly consulted Dr. Google. And Dr. Google threw up all this conflicting information. Don't take HRT, hormone replacement therapy. Take HRT, do this, do that. You know, and my head was reeling, and I found it really difficult to navigate the whole area. And then the third thing that struck me was, well, if that's my perception of a menopausal woman, I daren't say anything in work about having these hot flushes. And I would have had like 25 or 30 hot flushes a day, every day. And at night, the duvet would be on and off, and my sleep was broken. And I'm a great sleeper, and I love my sleep. And when I didn't get my sleep, it really affected me. So, but I didn't dare mention anything because I thought my colleagues and the management would say, oh, well, you know, she's kind of old, past it, crazy lady maybe, can she even do her job? And so I wanted nothing, no doubt about me, so I kept stum. So that was how I came about, that was my sort of journey about menopause. I'd never heard the word perimenopause before that. So as a result, all the symptoms that I had in my 40s that were related to my menopause and perimenopause, so perimenopause is the lead up to menopause when periods stop. And I didn't miss those symptoms, I experienced them, but I didn't know that they were related. So I had things like, I ended up in the eye and ear A&E department 3 times with dry eye. I had pains in my ankles. I had palpitations. I had urinary tract infections. I had put on about 10 pounds. I developed headaches, was sent for brain scans. I developed migraine with aura. But nobody mentioned menopause in any of these visits. I had brain fog, memory loss. We were even talking about it, trying to remember people's names. I didn't have any anxiety or depression, which a lot of women experience, but I did have what I would call a flat mood. So my mood was very flat and kind of no mojo, you know. And the list of symptoms goes on, to be honest. But as I said, I was totally unaware of those. I also developed asthma. I developed sinusitis. And so I was going individually to different doctors and specialists to get treatment for all of these. And nowhere in any of these visits did anybody mention menopause or perimenopause. So that was my journey. But before that, I had worked in the corporate sector. So nothing to do with medical, nothing to do with training, nothing to do with workplace education. And I worked in the corporate sector in marketing, communications and branding. And I was in very senior roles. I also worked internationally. I lectured in the Michael Smurfit Business School on their MBA and MSc programs, and I was on the board of the Abbey Theatre, and I chaired their Gender Equality Committee because it was a big issue around gender and having female playwrights. And I suppose it was that work that sort of gave me the confidence to know, and it gave me an understanding of the power of policy to change things. And I thought, maybe I can help other women. So anyway, after 3 years of putting up, this is a long introduction, but it's worth it. After 3 years of putting up with the symptoms I was aware of, which was really the hot flushes and just the hot flushes really, and the broken sleep, I tried everything natural under the sun because I was terrified of HRT, hormone replacement therapy. So I tried, supplements. I tried black cohosh. I tried donkai, sage, all different things. I even tried what I call my trusty magnet. So I bought this Lady Care magnet. It's called In Boots for €35. And the idea behind it is it helps with hot flushes, supposedly. And you stick it in your underwear, under your belly button. And it's supposed to help with hot flushes. So I don't know if anyone's ever bought one. But anyway, the only thing that happened was when I went into the supermarket, the wire basket went boom, and then the chain with the trolley boom. Oh no. So all I want to say is that, I feel I was a woman of the world. I was, fairly well educated, fairly well, fairly intelligent. And I was blindsided by my experience of menopause and all of the things that I tried to do. And I introduce that to make people laugh because it is funny, but it just shows you how vulnerable we can be when we're in a place where we don't know what's happening and we're not feeling at our optimal health. And therefore, we'll seek out lots of things. And so that's me sharing my story. So enough about me. Let's go in to talk about menopause, and hopefully you'll get a bit of an education around this. So, why does menopause matter? Well, by 2030, there's going to be 1.1 billion menopausal women on the planet. That will be 12.5% of the global population. So if you can imagine, 1 in 8 people on the planet, including babies and children, will be a menopausal woman. And 47 million newly menopausal women will come into the cohort every year. A lot of organisations and businesses have discovered that suddenly menopause is a hot topic, pun intended. And what they're doing, they've started to launch products. So now there's, for example, a shampoo, a menopause shampoo. Vichy have moisturisers that are specifically for perimenopause and menopause. So there's lots of products coming out. So that's a good thing and a bad thing. But a good thing is it helps normalise the discussion around menopause and makes the word more commonplace and less taboo. In the UK, there's 14 million menopausal women, of whom 4.4 million are in paid employment, and it's their fastest growing demographic. In fact, 52% of the workplace in the UK are female, whereas only 48% are male. In Ireland, there's 570,000 menopausal women, of whom 350,000 are in paid employment, and it too is one of the fast growing demographics. And for organisations, particularly healthcare and in the caring profession, females represent a significant proportion of the workforce, and therefore this topic is extremely important. Who are these menopausal women? Well, they're the wives, partners, mothers, sisters, relatives, friends, colleagues, bosses, direct reports, peers, teammates, and so on. So 50% of the population will go through menopause. Not every woman will be pregnant or have fertility issues or pregnancy loss, but every single woman will experience menopause. And the other 50% may be impacted by it directly or indirectly. That's why this is so important. And when we did our research, because no data existed in Ireland back in 2020, and we continue to do it every year actually, so we'll be updating that this September in time for World Menopause Day, which there is a World Menopause Day. 80% of women told us that they were unprepared for menopause, and 66% said they knew little or nothing about menopause. I can vouch for those because I was one of those statistics. And 79% rated the information and services as poor or very poor. And I was struck by, I went into my GP surgery, and I've been into a number of different GP surgeries over time, and I never ever saw a leaflet about menopause. I saw leaflets about lots of what I would consider, rare, maybe sort of obscure diseases. And no offence to anybody who's actually suffering with those. But for something that affected 50% of the population, I was really flabbergasted why there was no information leaflets about it. Now, things have improved in the last few years, and we'll talk about that in a bit more detail. In the research we did the following year, over 90% of women said that they had symptoms. 60% described them as moderate. So I had about 26 out of the 40 different symptoms. So I would describe my menopause as moderate. And then 30% described their symptoms as severe, meaning that they were debilitating and that they probably found it even difficult to leave their home. And then when we asked women about the impact in the workplace, just over 50% said their performance was affected a little at work, and over 30% said their performance was affected a lot at work. So I look back on my own experience, and although I would say, my performance was affected a little, the hot flushes were a bit of a killer, and the cardigan or the duvet, or the jacket, the cardigan in work was on, off all day. I had poor sleep at night, my energy levels were very low, plus all the myriad of other things that I was unaware of. So I would say, I felt like instead of walking on a flat surface, I was actually walking on a bit of an incline, and just everything just took that bit much more effort. When we asked women about, did they take time off work for their symptoms, 39%, so 1 in 4 women said that they took time off work due to their symptoms, and over 22% had missed 3 or more days. So that's time off work that really, could that have been prevented through supports? And over 80% said they wouldn't dare tell their employer the real reason for taking time off work. So they'd rather phone in and say they're vomiting or diarrhea than mention anything about menopause. So that's the statistics around sort of absenteeism and presenteeism. And when we asked women about leaving the workplace, 4 in 10 women, so in Ireland that's about 140,000 women, considered giving up work, cutting back their hours, taking early retirement. And 11%, that's about 38,500, actually gave up work. So they felt that they had no other choice but to give up work. And why do they say that? Well, they say that some of the symptoms, particularly the cognitive symptoms like brain fog, memory loss, lack of focus, concentration, forgetting words and so on, made them feel that they had to double guess, second guess, double check, and it made them feel like that they were less than themselves that they had been. And they also felt that, they doubted their ability to do the job. And women suffer with imposter syndrome anyway. So layer the hormonal piece and how they're feeling on top. And you can see why women have said they want to leave the workplace. The average age of menopause when periods stop is 51. And the average age of perimenopause, the lead up to when the period stops, when the hormones are fluctuating rapidly, is 45. So it's not actually an older woman's condition. And this is often the age when women are stepping into more senior roles, they are taking on more responsibility. We've worked really hard around diversity and inclusion and gender equality and the gender pay gap and so on. And yet, here is something that is preventing women achieving their best in the workplace. When we talk to women about confidence discussing menopause in the workplace, 60% said that they lacked confidence discussing with colleagues, 70% with line managers. And when we asked then women, what do you think employers should do in this space? Over 90% wanted training for managers and HR so that they felt if they needed support that they wouldn't be embarrassed and that their line manager or HR wouldn't be embarrassed or feel awkward and that they would know what supports to give. And over 95% said they wanted a menopause in the workplace policy, a living policy, not something that sits on the shelf gathering dust. So what is menopause? So I like to include some analogies that help, because there's some males in the audience, to help everybody understand what menopause is. Plus, I always think menopause is a bit like pension. You don't really think about menopause until you're near the age, just like you don't really think that much about pensions until you're near the age. So also to help younger people understand what menopause is. So it's really a catch-all word, if you like, for all the phases of menopause, which includes perimenopause, so I talked about that, the time leading up to the end of the periods when changes can start to happen. And this can start in the late 30s and early 40s. So once again, not an older woman's thing. Postmenopause then is a biological state of life when a woman hasn't had a period for 12 months, and then, 12 consecutive months, and therefore then you are postmenopausal for the rest of your life. I didn't know that. So I'm postmenopausal. And then really menopause is like one day. It's the day that your period stops, but you don't know that until 12 months later. Do you know what I mean? So it's a retrospective thing. And early menopause occurs before the age of 45 when periods stop. And then premature menopause, which is also known as premature ovarian insufficiency, POI, it used to be called premature ovarian failure by the medics, but they have renamed it because I don't think we ever refer to erectile failure, we say erectile dysfunction. So we need a bit of equity in this area. It can also occur because of illness or medical treatment. So, for example, this is obviously before the age of 40 or because of medical treatment or illness. So we have two women in our clinic. One is 22 and one is 21. And they went into premature menopause at the age of 15 and 17, respectively. So it can happen, much lower percentages, but it can happen in other ages. And also if women who've had maybe estrogen-positive breast cancer or some types of other illness need to take some other medication to suppress their ovarian function, they may go into what's known as premature menopause. And then finally, there's what we call surgical menopause. So if you've had one or both ovaries removed or a total hysterectomy or something, that can put women into what we call surgical menopause. And that's pretty abrupt. So women tell us that they wake up from their surgery and they already have symptoms, hot flushes and so on. So one of our doctors says, you know, the natural menopause, we have time to sidle up to it, or it is time to sidle up to us. But in surgical menopause, it's abrupt and almost overnight. So here's the chart to explain it. So menopause is really like puberty in reverse. And this chart shows along the bottom line the age of a woman and up the side estrogen levels in the female. And so as we enter puberty, the hormone estrogen surges up through our body, and if it doesn't touch every cell in the body, it has a conversation with every cell in the body. We have hormone receptors for estrogen in our brains, in our stomach, all over our body. And so that surge in the hormone estrogen results in lots of changes that take place for the female. So if anyone has a daughter or a niece, or you can remember back to the time yourself, all these changes happen, changes in body shape. We develop hips and breasts, weight might change, hair and skin changes. Do you remember acne, spots, greasy hair? Your sleep patterns change, your eating patterns change, mood changes, you know, slamming the door and everything. We all know about the teenage years, and we all give a lot of latitude to teenagers. Similarly, for males, there's a rapid increase in the testosterone, which results in lots of changes that happen to them, you know, in their genitourinary area, in their psychology, their mental, emotional, as well as physical. We won't call them symptoms, but signs. And they result in a girl becoming a woman, a male becoming a man. Now, usually what we do is we sit down with our children and we prepare them for this. We maybe take out a little booklet or a leaflet or something, and we give them the education about what to expect. We prepare ourselves. Society talks about it. We know all about it. But funny, when we get to the other end of the curve and menopause happens, there's been radio silence. It's been taboo. Unbelievable. So in the meantime, after puberty, we go into a phase of what's known as sexual maturity. Now, we as women know that it's nothing like as smooth as that curve there, and that every month it goes up and down, and if we get pregnant or if we have fertility treatment or whatever, that the hormones can play havoc. But in relative terms, that's the shape of it. And then as we approach the late 30s, 40s, we go into menopause, and then, as I said, we become postmenopausal, and we stay postmenopausal with a very low level of estrogen for the rest of our lives. Now, that didn't matter so much in the 1900s because women, the average life expectancy was 49 and menopause was 47. So women didn't tend to live that long postmenopausal. Whereas nowadays, we live a third to a half of our lives in a postmenopausal state, which means that we are at risk of other diseases like heart disease, brain disease like Alzheimer's, and bone disease, osteoporosis, because of this lower level of estrogen. And as I said, nobody sits us down in menopause or perimenopause with a little leaflet or a booklet or anything like that to explain what's to happen. And then nobody talks about it, so we think we're the only one. And then we might go looking for help. And up until recently, the medical help was very hit and miss. And so you might get treatment, you might not. So most women suffered in silence. And if I remember back to when I was growing up, we had women who lived in our area who had suffered with their nerves, who were taken to the bed, and other people in psychiatric institutions who were committed, who were in and out and so on. And so most likely that was menopausal symptoms. I'd really like for menopause to be as mainstream as puberty. And I'm convinced the reason menopause isn't openly discussed is because men don't experience it. I am convinced. Because what happens to men is that their testosterone level declines very gradually over time, and it never goes off a cliff in which the way in which it does for females. So hopefully that explains something. The other way to look at it as well is that estrogen is like the oil for the engine of the car, and therefore when the oil in the car starts to deplete, things start to go wrong, and that's the very same thing that happens to females. So this is a list of menopause symptoms. I won't go into it in detail, and I know there were lots of questions submitted in advance about this. But we divide them up. There's about 40-odd symptoms. We divide them up into mental, emotional, psychological symptoms, physical symptoms, and then genitourinary symptoms. And so on the mental, emotional side, we have things like memory loss, mood swings, depression, anxiety, feeling overwhelmed, weeping, crying, grumpy, irritable, bursts of anger, panic attacks, flat mood, loss of confidence. Sounds a bit like puberty, doesn't it? And what can happen here for some women, I didn't experience many symptoms on this side, but I am struck by the level of anxiety that women experience, particularly coming into perimenopause. And if you've never experienced this before, you think you're going mad. And that's what women tell us all the time. For women who have had previous instances of mental health issues, it may re-trigger or may trigger that again. So women going through puberty who have had previous mental health issues should be on the lookout for, just keeping their eye out for those kind of symptoms. The symptoms on the physical side are things like, as I said, hot flushes, night sweats, insomnia, lack of energy, fatigue, changes in hair and skin. Skin becomes very dry. Essentially, if you think that estrogen is the lubricant or the oil for the engine of the car, we're effectively drying up from the inside out. When I say that, I hate to say it because people start, feeling really uncomfortable and going, "Oh my God, is it really that bad?" My view on it is, if you're forewarned, you're forearmed. If I'd known about any of the things that were happening to me, were related to perimenopause, I would have had a very different 7-8 years. I wouldn't have had to go on with suboptimal health and go on with suboptimal living for so long. I mean, I never had to go to bed or stay in bed or take time off work sick or anything, but it was just suboptimal. So there's a whole load of things there, as I said: stiffness, aches and pains, digestive problems. I developed acid reflux, irregular periods. Periods can be a sign that there's something changing. And to be honest, because I wasn't looking out for the signs and my period stayed very regular, still 28 days every time, the little changes in pattern I noticed, but I didn't think about. Whereas women can have fewer periods, so more irregular. They can be lighter, they can be heavier, they can be much heavier. Women can experience flooding, which is like very heavy bleeding. That comes on, unexpectedly. They can be caught out at work or in social situations. The periods can become shorter, longer, and then they can have huge spaces in between, and then you have no period, and then you have a couple together or whatever. So they can be really irregular, but they needn't be. And also you can get hot flushes, but some women don't get hot flushes. So there are lots of different symptoms. And then when we get into the genitourinary, things like loss of libido, so loss of sexual desire, of sexual satisfaction and so on. And women don't often think of that in association with menopause. So that's why we have it on our checklist, which we give to patients before they come to our clinic. And they tick the various different boxes. And that prompts a conversation about that. So that means that can impact your relationship. Painful sex impacting relationships, vaginal dryness. And what happens is vaginal dryness, also known as vaginal atrophy, is one of those things that actually gets worse as we age. So it's really important to be looking at how you can help yourself in that area, and we'll talk about that. And then bladder issues. I said I had urinary tract infections throughout my 40s, incontinence, like urge incontinence or stress incontinence when you laugh, cough or sneeze, or some women will recognise that, or when you go running or whatever. I thought that was hereditary. I thought it was because I had 2 children. And the reality is that when you see those ads on TV that say, oh, it's okay to have a leak, just wear one of our always pads or whatever. The reality is it's not okay to leak. And if you do, you need to seek out assistance. That goes for men as well, actually. But this conversation obviously is aimed at women, but you need to go and seek out help. And there is lots of help available. So you can see there's a myriad of symptoms. And I just was thinking back to when I started my introduction. Having had my experience, I decided if I could wave a magic wand, what would I like to do? I said I would like to shortcut women's journey through menopause, so that instead of going 7, 8, whatever years I did in this, as I call it, navigating the wilderness, I would like women to have the information to shortcut that journey for them, to know that they're not alone and to be able to seek help. What they decide to do is up to them, but at least if they have the information, they can make an informed decision. So the values of the Menopause Hub are education, empathy. So what's happening is real, it's not in your head. And then empowerment to make the decisions with the information to look after your health. But at least you know you're making informed choices. So I set up the first menopause clinic in Ireland. There was nothing dedicated to menopause before that. Since we've opened a second clinic and we're trying to open a third clinic in Cork. So if anyone knows any doctors in Cork, I'm very happy to meet them and speak to them. Or Galway, or any other major urban centre for that matter. And the second thing besides opening the clinic, and the clinic is an evidence-based clinic, because what we offer is evidence-based, and it's around medical treatment, it's around psychological treatment, so we have a psychologist. CBT in particular is very, very important and a proven technique to help with some menopausal symptoms. We also have a dietitian and nutritionist who specialises in menopause, and we have a women's health physio who also, a pelvic physio, who specialises in that. And then the third thing we do is obviously menopause in the workplace training and policy development. So they're your symptoms, and I'm sorry if I frightened you, but actually if you're an alien and came down from space and somebody said, let's write all the things associated with being a teenager on a, hair growing where you didn't have it before, etc., you would end up with a very long list as well. But the fact that we're aware of it, we know what to expect. So, do I need blood tests? If you're under the age of 45, you may need blood tests, hormone profiling blood tests done day 2 to 5 of your cycle to determine if you're menopausal. If you don't have a cycle, they will still do the hormonal profiling blood tests. Now, if you're 44, I don't really mean this applies to you, but we're talking early 40s and younger. And if you're 45 or older, blood tests are not done routinely, and that's the international standard. So the British Menopause Society, International Menopause Society. The reason being is that your age and your symptoms are enough to tell us that you're actually in perimenopause or menopause. So just as you wouldn't take your teenage child to the doctor to say, can you confirm they're in puberty? You don't need a blood test to determine that you're in menopause. And if your periods have stopped, you definitely don't need to have blood tests. And women say, well, how do doctors know what to prescribe? So it's not a scientific calculation. You and I could have the same blood test results, but we could have very different symptoms. I could have none and you could have lots. Or you might be able to put up with your symptoms and I may find them very difficult and not able to put up with them. So our doctors treat patients, treat women, treat symptoms. They don't treat blood test results. So the long-term impact, so here's even more good news. The long-term health impact of a lack of estrogen is that it impacts our heart, our bones and our brain. So the number one killer of women globally and in Ireland is actually heart health, heart disease. And it increases and overtakes that of men by the time we go into postmenopause. And therefore, the fact that we know the signs and symptoms of a male heart attack and not a female heart attack, I think is pretty shameful. But anyway, so heart disease is one of the risks. The other one is osteoporosis. So we lose 2% of our bone density a year, and once we become postmenopausal. And that puts us at greater risk of fracture, and 1 in 2 women in Ireland will have an osteoporotic fracture in their lifetime, and 20% will be dead within a year. The third area is the area of brain health. Women are 3 times more likely than men to develop Alzheimer's, and we have estrogen receptors in our brains, and therefore that's the reason. So amyloid plaques can set down in the brain, plaque sets down in the heart, and bone density declines, all due to the loss of estrogen. So there's longer term issues for us as well. So what I will say is there's no need to suffer in silence. There's lots of treatment options available, and the cornerstone is diet and lifestyle. And I say that because we can do a lot to help ourselves around our diet and lifestyle. It may not be the silver bullet, but it certainly can make life a little bit easier. Women who are overweight or obese actually tend to have worse menopause symptoms than those that aren't. Women who smoke have worse menopause symptoms than those who don't. So the things you need to do here are things like you need to cut down on your calorie intake. So we're not burning up the calories in the same way as we did before because we're aging. But secondly, our body now sets down fat in a different way. It sets it down as brown or visceral fat around our organs rather than subcutaneously under the skin. And as a result, that's the more dangerous fat. So that's why we get middle-age spread. And that's because of the decline in estrogen. The things we need to do is reduce our calorie intake by about 500 calories a day forever. We need to take up weight-bearing exercises because that's really good for our bone strength and our muscle mass. And we need to do that for 15 or 20 minutes a day forever. I sometimes feel a bit hypocritical because I don't always do this myself. But anyway, I do try. We can cut down on our alcohol, cut out smoking, and move towards a more Mediterranean diet. And this is all the information we all know. You know, it's all the really boring stuff that we know and we need to be doing, but we just somehow or other sometimes don't. But move to more Mediterranean, maybe increase the protein intake and reduce the carbohydrate intake. And we need to take vitamin D because we live in the northern hemisphere, so most of us need vitamin D. And that also helps with our bone health. You can take magnesium and your vitamin C and so on, but they're really the most important things to do. If you are looking to kind of increase your exercise, you can walk a minimum of 10,000 steps a day, but I'm sure many of you walk more than 10,000 steps a day. So if you're at 15, you need to go to 20. Do you know what I mean? It's about increasing the exercise out. But I do know that people are on their feet and work in hospitals and big buildings, whatever, they walk. My son's a secondary school teacher. And he says to me, 10,000 steps? Sure, that's a doddle, you know. So that's your diet and lifestyle. Next is herbs and botanicals. So women tell us that sage can work very well for hot flushes. There's phytoestrogens can work well for hot flushes, although women who have breast cancer can't take that. The phytoestrogens are about 100th to 1,000th the strength of what we have naturally occurring estrogen in our bodies. You can try black cohosh, although it's banned in Ireland. It actually interferes with blood pressure medication. There is Menomin, Menopace, Menopure, Menorevive, all those Meno-type products. They are supplements. They don't have estrogen in them, but you can take them. And some women tell us, look, that they get great results from those, but most women tell us that they don't. And there's very little research or evidence base around it, very little scientific research. And I know I've done this exercise myself and gone to a Whole Foods natural, shop for herbs and so on. And, I said, I'm suffering menopausal symptoms. What can you prescribe? And they said, what are your symptoms? And then they proceeded to give me a different thing for all the symptoms. So I left with, 150 quid's worth of stuff in my basket that I had to take over the time. So, I just think you need to be aware of what you're buying into. That's all. The next thing then is HRT, hormone replacement therapy. I went on HRT, and actually that's what was a game changer for me. All of my symptoms went. I get a full night's sleep, and all my symptoms are gone. And I started to feel great, and I got my old self back again. And effectively, I would have said I had the average length of time of menopause symptoms between peri and postmenopause is 7.5 years. I would have said I had symptoms for about 8 years before I actually started on HRT. Excuse me. Hormone replacement therapy has had a very bad rap. I was anti-HRT, by the way, so, you know, I'm coming from the position of a lot of women. It's had a very bad rap. In 2002, there was a study done called the Women's Health Initiative. And what they found out was, the headlines were published before it was ever peer-reviewed. And they went out over the world, all the newspaper headlines and whatever, and they said HRT is dangerous, it causes breast cancer, stroke, heart disease. What had happened was the research was, as I said, never peer-reviewed and sort of taken out of context. Not sort of, it was. And the authors of the research have since come out and apologised to women about it, because what they were actually doing was researching. The average age of the women in the research was 63. They were overweight, obese, and were smokers with heart disease. So they have apologised to women, and as a result, you know, women have started being interested in HRT again. So the types of HRT that's available nowadays is, and the safest is seen as what's called transdermal. So it's delivered through the skin, through gels, patches and creams. And as a result, it doesn't go through the liver and is seen as a safer route of delivery. The hormones that are available are estrogen, progesterone, and if you have a womb, you have to take progesterone. And then the other one is testosterone. I take testosterone, actually. I didn't know that women needed testosterone, nor did I know that they could take it. So I have to say, it was a surprise to me. That can help with libido, and then there's a lot of anecdotal evidence to say that it helps with focus, concentration, energy, va-va-voom, that kind of thing. And then there's also a local pessary that you can insert into your vagina, very, very, very low dose, that helps with that vaginal dryness. So that's localized, it's not systemic. So there's estrogen, progesterone, and testosterone, and then a local vaginal estrogen. If you don't have a womb, you don't have to take progesterone, but some women do, but you don't have to, because the role of the progesterone is to keep the lining of the womb thin. And if you have periods, you will be put on a cyclical cycle, which means that it will still kind of imitate your periods. If you're not on don't have periods anymore, it'll be on a continuous cycle, which I'm on. So that's HRT. The risks for most women are small, so the benefits outweigh the risk for most women. But you need to obviously get that checked out, depending on your own health history, family history, and so on. There's also non-hormonal medical options available, and they would be for women who can't take HRT or don't want to take HRT, and they can help with hot flushes, with mood, with sleep, and so on. And so a lot of women say who've had breast cancer that is estrogen positive who can't take HRT might come and have that prescribed by our doctors. So there are lots of options available. One of them actually is an SSRI, or an antidepressant, and that is seen as a second-line treatment. So if women can't take HRT, that would be offered. SSRIs shouldn't be offered as a first-line treatment, but during the time that doctors stopped prescribing HRT because of that big study, antidepressants became one of the things that were prescribed because it helps with hot flushes and also helps with mood and sometimes can help with sleep. But it's not a first-line treatment anymore. Then we have CBT, cognitive behavioural therapy. So as I said, that's a proven technique, and it can help with hot flushes, sleep, and anxiety or panic attacks. Our psychologist is trained by the British Menopause Society in this, so you can get that. And then there's pelvic physiotherapy. And this is delivered specifically for the pelvic area, because the loss of estrogen means that our pelvic floor also gets weak. So that's your treatment. No need to suffer in silence. So why is menopause in the workplace important? Well, there's, I think, a very compelling business case for changing the way we think. First of all, we have a duty of safety and well-being to our staff under the Health and Safety Act. We also could have performance issues, and like any other performance issue, what we have to do is we have to support our colleagues through this. And then finally, there's what's called talent retention. So we said 10%, 11% of women leave. And going forward, I think talent attraction, having a menopause policy or menopause supports would be really important. The next thing is the legislative risk. So there's also been an increasing number of tribunals in the UK, now one pending in Ireland, Menopausal women have taken cases and won on 3 grounds. On the grounds of gender discrimination, age discrimination, and disability discrimination. Now, we don't want menopause to be considered a disability, but a woman in the UK had symptoms of menopause that were so chronic that they spilled over to her overall health condition, and therefore she took a case and won on the grounds of disability. So in the UK, they've looked at introducing menopause as a protected characteristic, but what they've done is it's been rejected for the first time after the first submission by the Equalities Commission on the grounds that it discriminated against men. They will be going back around that to request that. But in the meantime, what they've done in the UK is they've appointed a national menopause champion for workplaces, and I've requested that from the Overadcar actually. And they've also they're looking at introducing menopause policies being legislatively required by organisations over 250. So you can see that there's a lot of movement in the UK. The UK and Ireland are the most advanced in the world around menopause and around menopause policy. So in lots of countries, particularly the US, is only kind of waking up to this whole area. Continental Europe, not really. So you'd be surprised. So we're pretty advanced. By hosting this event today, you're very advanced. We've just launched, with Great Place to Work, the Menopause Friendly Awards. So basically, there's a submission date of the 8th of September. So if you want your organisation to be recognised as menopause friendly, you can put in a submission. There's a website called menopausefriendly.ie where you can read more. But this is an initiative to encourage organisations to become more menopause friendly and to see other organisations and want to copy them basically. We work with a ton of different people. I won't go into that. But the last slide before we move on to the Q&A is that what is the best practice for menopause in the workplace? Well, this is what organisations are doing, raising awareness through things like this, talks, posters, health programmes, organising social support. So the appointment of menopause champions who could be a peer-to-peer support. They can be a listening ear, a signed poster. They can offer social support in the workplace. But the real secret, I think, or opportunity to support women comes in the area of reasonable adjustments. So flexible and agile working, job sharing, working from home, that kind of thing. Reasonable accommodation in terms of maybe the working environment, aircon, desk fan, sitting beside a window, something like that. Restroom or rest area, changing facilities for women who may need that. Access to cold drinking water. For some organisations, they have all of these. They've got pool rooms, they've got bean bags, they've got everything. But there's lots of organisations, and many of you will know them, that don't have these. There may be uniforms or work clothes, and the actual design may be incorrect. The material may be too heavy. There mightn't be enough pieces. Managers need training, so they discuss with staff. They don't prescribe. And we need to encourage women to speak more about this, as these feelings are very real. You can also get HR training. For some roles, you may need to do risk assessment because those roles may be high risk, and if people are having some of the symptoms we described, it could be an issue. And ultimately, introducing a menopause in the workplace policy. I think they're the top things. 2 other things. One is we need male allies. Really important to have males involved in this conversation. Otherwise, it becomes just a women's issue. And then secondly, we need senior leaders in the business to come out and talk about their own experience so that they open up the conversation and say that it's okay to have these conversations. And the whole thing about it is it needs to be a living, breathing support in the organisation, not just a policy. And then the last thing I'll say is that there are 5 symptoms that affect women most in the workplace. And what they tell us is the number 1 is cognitive. So focus, concentration, memory loss, forgetting words, forgetting names, like us too. She says no. But that's the most important, the cognitive. The second one, and that's in 75% of cases, the second one is actually fatigue and no energy, and that's in about 66% of cases. So if you've had insomnia is very big in menopause and perimenopause, but if your sleep is broken, to go to the loo, to hot sweats, hot flushes, whatever, then that's another one. The third one is feeling overwhelmed. So women who are really capable in their roles are now, with the hormone fluctuations moving in, feeling overwhelmed in their jobs, in their lives. And that was in 57% of cases. Anxiety, 55% of cases. And actually hot flushes was 46% of cases. So you can see it isn't all about the hot flushes. So that's it. We can move on to a Q&A, and I hopefully have answered some questions throughout this for some people, but I can pick up others that I haven't answered.
Thank you.
Sorry about the coughing fit in the middle.
I'll give you a minute there just to say, look, thank you, and what an amazing amount of information. I'm like trying to process it all now, so thank you for all of that. And actually, I think the thing that really resonated with me, and you said about when you were first, I suppose, when you first knew you were in menopause, and that feeling of like, you know, to battle, you to hide it and work, you just get on with things. And like, I think that's my default position as well, is like, hide it, push through, it's fine, I'm grand, it's all good. And actually, I think it's so important that we do keep these conversations going, and that we are open with our colleagues and our friends and husband and family members about how difficult it is and how it does affect us. So I think, look, this is the first step for us today as in Community Healthcare East, being more open and having these conversations. So, we might start with some of the questions. Yeah. And there's a few there that people put through at the time of the booking, and then I think there's some coming in on the chat.
Brilliant. The thing I was going to say is, so for having people like yourself coming out and speaking about it, having somebody, well, like me, but I'm not part of your organisation, the more people we have, you know, the better I think it is. And then it says, you know, this can be a safe space. So some of the questions that we haven't answered, somebody said in other European countries, they now have menopause leave for people really struggling with symptoms. Well, they don't have it that I know of in very many countries. I think Spain have introduced stuff around menstrual leave. The UK have got organisations introducing it. In Ireland, we have the banks. I know they're much more wealthy than a lot of other organisations, but they've introduced, Bank of Ireland introduced 10 days menopause leave. So Vodafone have menopause leave. Channel 4 in the UK, BBC, the Metropolitan Police. So there's a lot more organisations coming out. But I think, I don't think you need big things like that. I think you need the smaller things that make everyday work more bearable, so that you feel supported. And then small things can make a big difference, so it doesn't have to cost the earth. That's what I think. The second thing I was going to say is, so will Ireland ever follow suit? Well, I think Ireland is following suit, to answer that question. Someone said, I'm really tired all the time. Is it menopause? I would just say, are you over 45? Do you notice any other things from that checklist? And it's available on our website, because it's very difficult to answer that question. First of all, I'm not a medic. Secondly, even if I was a medic, we never give individual advice without a full consultation and history and family history and so on. So the likelihood is it could be menopause, but it may be lots of other things. So it depends on what category you are. So that's why we provide some of those tools like the symptom checker and so on to help people. So investigate that, but also make a trip to your GP. Someone says, I haven't had children, recently been experiencing urinary leaks. I wear a pad every day. Is it menopause? What will help? Well, I don't know your age. I don't know, well, I'm not a doctor, but I don't know your age and so on. But if you are in this age group, it may well be connected, and it's definitely worth investigating and checking out. And as I said, wearing those pads and leaks are not normal. There was one there about ankles, knees, and so on. Yeah, that's, you know, if you're in the age group, yeah. The next one was, any advice on how to stop, reduce night sweats? Any ideas, tips for how to cope and work when colleagues are cold and want windows closed, and you're having a hot flush and need some air? Yes, I've been in that situation. So to stop and reduce the night sweats, you can go and seek medical treatment for that. That is a possibility. In terms of, other than that, it's a fan in your bedroom, it's a window open, it's maybe having different duvets on the bed between you and your partner. It may be, there's lots of products now available, different types of sheets. There's lots of devices that are available there, but there is medical intervention. The other thing was how to cope in work with colleagues. So it depends. I know in areas where there's a risk of virus and so on, you can't have fans. But if you're in offices, you might have an individual desk fan, maybe. I had one of those actually, because one summer it was really hot and we had this row every day. about the windows and not the windows and the doors and the aircon, and it was just awful. Some people sat with blankets on them, and others were like, in their t-shirts. So they came around and issued desk fans, small desk fans, and honestly, it was a lifesaver for me because I wasn't on my HRT then. The next one is, hi, I only have mild menopausal symptoms. Should I visit my GP to get my bloods checked for estrogen levels? Well, it depends on your age, but if you're over the age of 45, no. And if I'm not on treatment, have I a higher risk of developing osteoporosis later on? Well, the simple answer is yes, you do. If you have a family history of osteoporosis, you should get what's known as a DEXA scan, a bone density scan, which will assess your sense of your level of risk factor. And the surprising number of women who come to our clinic have had a DEXA scan and they have osteoporosis or osteopenia in their late 40s and 50s. So that's why that, weight-bearing exercise, using your own body weight, and vitamin D is so important. And I've read recently that vitamin D3 and K2 in a supplement, which I take now, and I don't sell supplements, so I'm not promoting supplements, is the best way. One helps the other absorb more into the bone. I hope that helps answer that question. If your period has not occurred for over 2 years and suddenly it starts up again but very light, what does this mean? It means you have postmenopausal bleeding and you need to get that checked out. It would be considered quite an urgent thing. I'm not saying there's anything wrong. There may be absolutely nothing wrong, but it's known as postmenopausal bleeding, and it could be a sign of an endometrial issue or something like that. So there are PMB clinics in the big women's, like Holles Street has a PMB clinic, I think Coombe has, and Rotunda and so on. So I would go and get that investigated if I were you. Just to put your mind at rest, it could be nothing, but it might not be nothing. Sleeping pattern, how can you get a good night's sleep and not be waking during the night? I presume this woman is menopausal. Does this leave you with less energy? Of course it does. And what it means is that there's a domino effect on the symptoms. So the less sleep you have, the more cranky you are, the less your cognitive function is, and it becomes this, vicious cycle all the time. Progesterone is a natural soporific hormone. So soporific means it helps you sleep, would you believe? And what happens is our progesterone is declining, and that's one of the things that causes this lack of sleep. So a lot of women say once they've started on progesterone that they can get their sleep back. But there's lots of things that you can try before that around sleep hygiene. I used to go, that's a load of rubbish, but actually it seemed to be scientifically very good. So sleep hygiene, turning off the blue screens and rest and calm and not on devices and stimulating yourself before bed and all the rest. The other thing is there's such a thing as, obviously, CBT, cognitive behavioural therapy, but there's also ICBT, which is for insomnia CBT. So if you've got something else and you've tried lots of things and it's still not working, you can try some of those things. You may need to check out and go to a sleep clinic if it's really bad, if you don't have sleep apnea or something like that, or if you have a snoring partner or whatever. Do you know what I mean? There could be multiple. Sleep is a big issue, particularly for menopausal women. The next one is, can you stay on HRT for life, and how do you know if the doses on is protecting your bone and heart health? Well, there's a minimum level to protect your bone and heart health, so that's the first thing. And then the second one is, can you stay on HRT for life? If the benefits outweigh the risks to you, and you are still getting benefit, the latest data says that yes, you can, but you need to monitor this closely. You need to have your blood pressure checked. You need to have a visit with your doctor, at least annually, if not twice a year. So in theory, yes, you can. I've been on mine a good few years now, 6 years, I think, and I'm planning to stay on it for as long as I can. Are there HSE clinics or support other than GPs and private clinics for women to access? Well, there was HSE clinics set up, and there's one in the Rotunda, one in Holles Street, one in, I think, the Coombe, one in Limerick, and a couple, they're trying to set them up around the country. But they're for complex patients. So they're not for the everyday woman. They're only for complex patients who typically have breast cancer, who've had a stroke or heart disease or something like that. I know the Rotunda only sits one afternoon a week or something. So they're very limited in the resources. They only serve a certain catchment area, and you have to be a complex case. So the answer is sort of, but not really. But it's a step forward because they didn't exist a couple of years ago. And menopause in the work, what supports do women in nursing have beyond EAP? Well, I think probably they need to ask somebody in wellbeing about what that is. EAP can be helpful, but there's also a lot of video on the HSE portal, from what I understand, on YouTube that you can access. I happen to be delivering one of those in a panel discussion before. Deirdre Lundy has given some, etc., etc. There's also on the HSE website, there's information that's been updated about menopause. So I think there's a fair bit nowadays. But apart from that, I think you'd have to approach somebody more in the know than me.
Yeah, chat to your line manager, chat to colleagues as well. Yeah, and definitely seek out the health and wellbeing supports.
Yeah. Okay. There's a few questions there.
There is, yeah.
Oh, yeah. I have a Marina coil and I don't have periods, so it is a blood test relevant? Well, first of all, if you're over the age of 45, the blood test isn't relevant anyway. Secondly, if you're under the age of menopause, of natural menopause, then you should get that checked out. The Marina coil actually provides the progesterone element of your, so it's the progestogen element of your menopausal, of your HRT actually. So women can take that not necessarily for pregnancy, for contraception. They can take it as part of their HRT treatment as well. And what some women say is if they have the Marina coil and they get it taken out, that they do find their symptoms kind of start. So it can help kind of, kind of maybe delay some of the symptoms, but not always either. But no, your age and symptoms will be the telltale. So that's one. I missed the intro. Could you introduce yourself again? Well, I won't go into the big, long introduction. I'll just do Loretta Dignam, founder and CEO of the Menopause Hub. And where is it? Well, we have a clinic in Mount Marion and we have a clinic on the north side of Dublin at the entrance to Northwood in Santry. Thank you. Excellent discussion. Much appreciated. Thank you. I had to read that out. No, I'm really joking. Oh, God, I take Axiban for a clotting disorder. My GP reluctant or whatever. Can I take any? You would have to go to somebody who's a bit more specialist in menopause. I couldn't answer that question. I'm sorry. I would encourage women not to suffer in silence. Please talk to someone. HRT has really helped. Yeah, there is, a lot more conversation about HRT. I'm not saying you should take HRT or not take HRT, but you should know about the risks and benefits. And for example, if you're overweight or obese with a BMI of over 30, you are double the risk of the natural population of developing breast cancer. A lot of women don't know that. If you drink 2 units of alcohol or more a day, you increase the risk of breast cancer more than taking HRT. If you exercise and do 2.5 hours of moderate exercise a week, you actually reduce your incidence of breast cancer. If you take estrogen only, you reduce your risk of breast cancer. If you take estrogen and micronized progesterone, it's called, which is the bioidentical progesterone, which is called Utrogestin, you actually decrease your risk of menopause of breast cancer. So, there's a lot of misnomers about that. Then we have, I don't know. Are all women at risk of...
Are women at greater risk of dyslipidemia post-menopause?
I don't even know what that is, I'm afraid. I'm showing my ignorance. Does anyone know what that is? Google it, yeah. Somebody's going to come up and give us it. The next question is, what are my thoughts on CBD oil for symptoms? Well, my understanding is that there isn't a huge amount of research on that, but it seems to be emerging, like CBD oil is for everything in the States. So, I mean, if you try it and, high cholesterol levels, imagine I didn't know that. So I think if you want to try it and if you get benefits, some women, I see stuff coming through on the internet and on kind of alerts and things about CBD oil, and some women saying that they get benefits from it. So if you want to give it a try and it seems to work for you, then I wouldn't see, I don't know the risks. But maybe do a bit of research around it. And there's a lot of support groups online. So there's one, for example, called the Irish Menopause. They've over 50,000 members on that. So therefore you can find out a little bit about that. And if you find anything out, feel free to send it in to us. And then that question was about high blood pressure, wasn't it?
High cholesterol.
Oh, high cholesterol. Yeah, that can be affected by actually the decline in estrogen, and therefore, you need to have all of these things under control as well before you can start HRT. So if you have high blood pressure, you need to get that under control before you start heat or tea. But yes, the decline in oestrogen can put your cholesterol levels, can send them a bit haywire as well. So a lot's going on there, I'm afraid. It's all good news, isn't it?
I think you've answered all the questions. Thank you so much. Look, just to wrap up, I really want to thank you for your time and expertise. I also want to thank Jim Gorman and the Community Healthcare East Menopause Working Group. On behalf of the Health and Wellbeing team, I'm delighted that we were able to start this conversation today with you all. The Community Healthcare East Menopause Working Group is planning more activities in the future, including another webinar that will dive into more specifics around menopause and mental health. The group is also working on material to signpost staff to resources available. This isn't the last you will hear from us on this subject. Today is just the start. As mentioned earlier, the webinar will be available to watch back on our Community Healthcare East YouTube channel, so please let your colleagues know. And now you all know why I can't remember anybody's names. Thank you.
And the last thing I can say is, please go forth, and this is my challenge to you, as menopause ambassadors, and start opening up the conversation to normalise it so that one day it's going to be like puberty.